So everybody, welcome to our webinar, which we are proud to present in collaboration with Cleveland Clinic and IndoUSRare. As you know, our presenters will talk about taking care of your aorta when you have Marfan syndrome. More than 240 people have registered from all over the world. So it's great to see so many of you here for the live presentation. The Marfan Foundation's mission is to save and improve lives while creating communities for all individuals with genetic, aortic, and vascular conditions, including Marfan, Loeys-Dietz, and vascular Ehlers-Danlos syndromes. Together with our partners around the world, we are committed to serving our community no matter where you all live. The foundation has a long history with Cleveland Clinic, but this is our first time partnering with IndoUSRare. So the first thing I'd like to do is invite Nisha to tell you about this organization. So Nisha?
Thank you, Eileen. If I could just bring back my screen.
Yes. Great.
Give me 1 second. Would you allow me to share screen, please?
Oh, you want to? Okay, sure. Of course.
Thank you. Are you able to see my screen?
Yes.
All right. I'll just take a couple of minutes just to introduce you to IndoUSRare. Before I begin, I want to take this opportunity to thank Eileen for this chance to partner with the Marfan Foundation for this incredibly informative webinar. And we're honored to be here with you and all the experts here on the panel today. Looking forward to learning from you and hoping that a lot of people from India and the community that we serve across the world, the Indian diaspora, will benefit from this. I'm very, very excited. We are the Indo-US Organization for Rare Diseases, and our motto is to empower rare lives by bridging nations. The core gap that we were founded to address is the inequity that exists in access to clinical trials and the lack of representation of populations, specifically Indian diaspora, in clinical trials resulting from various causes, including underrepresentation of the Indian population in genetic databases and rare disease registries, and really poor engagement and inclusion of people of Indian origin in rare disease research. Our mission is therefore to connect, collaborate, and bring together all stakeholders of rare diseases from across the world, with a particular focus on the Indian diaspora through conferences and other events, and to drive cross-border research and to advocate at national and international levels. We do this through 6 main programs, and I want to just walk you through a few of these. Tech-enabled patient concierge is a program through which we are able to provide personalized support to patients reaching out to us from anywhere across the world. We have a platform through which we are able to communicate through them in an omni-channel manner in a language that is comfortable to them. And so far, we have supported inquiries from around 15 countries, spanning 4 different continents. We are honored again to have Marfan Foundation as part of our Patient Alliance membership. And as you can see, we are disease agnostic, and we partner with various patient advocacy groups from different parts of the world. And we have found that there's commonality across all of these different diseases, and the shared experiences help bridge the gap that exists in the rare disease community. We undertake a number of research programs, including the Research Core, which is an increasing network of experts, geneticists, physician scientists, and academicians from across the world with a specific interest in rare diseases. And we also undertake grant-funded research programs. We've just completed a program understanding the awareness about rare diseases among the teachers in the Indian population, specific to the Indian continent. And this was from a grant from Amgen. And our in partnership with the RDDC, the Rare Disease Diversity Coalition, we have worked to understand the state of diversity, equity, inclusion, and accessibility in rare disease clinical research. This paper is under revision in a peer-reviewed journal right now, and we hope to be able to share it widely soon. Various educational and awareness programs, including webinars such as this one, Rare Disease Day events, art competitions for children, walk and run events, and quiz to engage the population to make sure that people at least have an idea of what the concept of rare is, and our annual events. We also advocate for the rare voice at all the international forums where we are speakers, as you can see here, and we understand the importance of creating accessible materials through translating pamphlets and even a children's book in partnership with the Rare Parent and Son duo. As you can see here, we've made it available in Hindi and other Indian languages for access in India. We advocate in the US and internationally, and in India at the national level. Our flagship event, the Indo-US Bridging Rare Summit, the first one was held in Arlington in 2023. And most recently, our second edition of Summit was held in New Delhi, and it was well attended by over 500 individuals from across the globe. And stakeholders include from the ministries and the need for cross-border collaborations. And we hope that this will catalyze numerous partnerships, such as what we have now with the Marfan, and drive innovations. Our next summit is in November in the George Mason University in Manassas, Virginia, and we invite all of you to be there. And we hope, Eileen, you will be there in person with us this time. And I just want to give a shout out to all of our partners, the organizations with whom we are honored to be partnering with, our corporate alliance members, our patient alliance members, and everyone who we have worked with. Anyone who wishes to engage with us, who wants to know more, please write to us at admin@IndoUSRare.org, and we can work in any of the ways that are mentioned on the screen. Thank you to the Marfan Foundation for this opportunity, and thank you to everyone who supported us throughout the years. We just celebrated our 5th year. Thank you.
Thank you so much, Nisha. I mean, that was really great. I'm glad to see your next meeting is in Virginia. That makes it a little bit easier for us over here. But I was impressed with the poster I saw that you presented at NORD a couple of years ago, and that's how I got connected to you guys. So thank you for the great work that you're doing. So our first speaker, let me just get back to my slides here. So as I mentioned, we have a great lineup of speakers. Dr. Desai from Cleveland Clinic, Dr. Kalahasti from Cleveland Clinic, Dr. Prakash from University of Texas in Houston, Dr. Sultan from University of Pittsburgh, and then a patient perspective from Adam Haniff, who also is a doctor as well as having Marfan. So for our first presentation, I'd like to first introduce Dr. Kalahasti from Cleveland Clinic, and he's going to provide an overview of the aorta and Marfan syndrome.
Everybody hear me?
Yes, you can go ahead and share.
Yeah, thank you so much, Eileen. It's a great opportunity to present at this webinar. And I've done a few of the webinars, as you know, with the Marfan Foundation. It's always very exciting. I'm going to share my screen. You're able to see the screen?
Yes, you're perfect. Thank you.
Okay. So what I'm going to do in the next 10 minutes or so is to briefly go over the diagnostic criteria for Marfan syndrome, and then review the spectrum of aortic disease that we typically see in patients with Marfan syndrome. As you know, I always start my talks with any of the aortic aneurysm patients, particularly with Marfans, is there is no disease more conducive to clinical humility than the aneurysm of the aorta, and I feel and perceive and experience this on a daily basis in my practice. And that's very true even with Marfan patients with aortic aneurysms. Now, and this is the spectrum of all the genetically triggered thoracic aortic diseases. And we broadly divide them into three different categories. One of them being the disorders of the TGF-beta signaling pathway, disorders of the smooth muscle contractile apparatus, and then disorders affecting collagen. And this is a very complex diagram. I'm not going to go into all the details of it, but suffice it to say that both the Marfan's and the Loeys Dietz spectrum patients, they all have mutations in different genes that that cause these diseases. And fibrillin, as you know, is involved right in this area here. And what does that lead to if you look at the presentation of a Marfan syndrome? It's a connective tissue disorder caused by mutations in the fibrillin 1 gene. What does that lead to? It leads to fragmentation, loss of elastin fibers, decreased density of the smooth muscle cells, an increase in proteoglycan deposition. And it is an autosomal dominant disorder with multiple organ systems that's being involved. What we're going to focus on today is about the aorta. And apart from aortic aneurysms, it also causes ectopia lentis and disproportionate long bone growth with the prevalence of about 6.5 per 10,000 people. And in fact, Marfan syndrome has been reported in every country and all ethnicities. And the cardinal feature of Marfan syndrome is the aortic root dilatation. And that's what this image shows here. If you look at the diagnostic criteria for Marfan syndrome, we broadly divide them. Again, this is the revised Ghent criteria from 2010. And what these criteria laid emphasis to is what are the most important and the cardinal features of patients with Marfan syndrome. And the first branch point that we look at is, does the patient have a family history? So let's start with those patients without any family history of Marfan syndrome. And if you have no family history, the burden of proof needs to be more. So you can diagnose Marfan syndrome in those patients without a family history. By the way, about 20 to 25% of patients do not have a first-degree relative or a parent with Marfan syndrome. So it is not uncommon. And so it is very important to diagnose those patients because they may not, with the family not showing the features of Marfan, sometimes the diagnosis may be delayed. And so these criteria emphasize the cardinal features, including if you have an aortic involvement with a z-score of more than or equal to 2, or history of aortic dissection, and you've been diagnosed as having ectopia lentis, so that gets you a diagnosis of Marfan syndrome. Or if you have an aortic root involvement or an aortic root aneurysm, and genetic testing shows a fibrillin 1 gene mutation, that also gives you a diagnosis. Aortic involvement and systemic score, and I'll share that in a couple of slides, more than or equal to 7. Or sometimes you do not have an aortic involvement, but you still have the diagnostic criteria based on ectopia lentis and fibrillin mutation. How about those patients who have a family history? So here, because there is already a family history, any of these features, along with the family history with either an ectopia lentis or an aortic involvement or a systemic score, more than or equal to 7 leads you to diagnosis of Marfan syndrome. And what are the different systemic features that we think about? There are many different features that most of you may be familiar with already. If you go to the National Marfan Foundation website, they have a very nice diagnostic criteria page, shows all these images. And in fact, these are all taken from there. So some of the things we look at is very long hands and fingers with the wrist and thumb signs. If you have both of them, 3 points, so on and so forth. I'm not going to go over all of them, but these are the most important systemic features that we always think about, and some of the other ones being the facial features that most of you are familiar with. So the maximum total points come up to 20. If you have more than or equal to 7, that signifies systemic involvement. Some of the other features, because they do not have a specificity, they're not always routinely used as part of the scoring system, but you do still see them as features in individual Marfan patients. So after you made the diagnosis, what are the things that you need to think about from an aortic aneurysm standpoint? And this picture here is taken from the ACC/AHA guidelines, and this shows the entire extent of the aorta. And just for those people who are not in the medical field, I'm just going to briefly go over that. On the right side, you can see the CT scan of a patient with an aortic root aneurysm. So the aorta starts with the aortic sinuses, and it's commonly used similarly as an aortic root, sinuses of Valsalva. So that's connected to the left lower chamber of the heart called the left ventricle through the aortic valve. So this part is the most common part of the aorta that's involved in patients with Marfan syndrome is the aortic root aneurysm. And this is the tubular ascending aorta that connects to the aortic arch. These are the blood vessels coming from the aortic arch, supplying the various cranial organs to your face and brain, right arm and left arm. And this is the descending aorta that goes behind the heart. And the aorta passes through the diaphragm and becomes the abdominal aorta. And these are the branch vessels coming from the abdominal aorta, supplying your abdominal organs, including liver, spleen, and kidneys. And this is below the kidney artery, part of the aorta, and then these are the common iliac arteries. So that's the entire extent of the aorta. And as you can see in this particular CT scan, looking from the front of the body, so this is your right lung here, left lung here, the heart is on the left side, and this is the aorta, and this part is the aortic root, and this is the aortic valve connected to the left lower chamber. And the aortic root aneurysm is the classical finding in patients with Marfan syndrome. So what are some of the important things that we know and very well established in the literature as to the spectrum of aortic disease in patients with Marfan syndrome? As I said, dilatation or aneurysm of the aortic root is the most frequent. In general, aortic dilatation is much more common or greater at the root compared to the tubular ascending aorta. Most of the literature suggests that the aneurysms involving the aortic arch or descending the thoracoabdominal or abdominal aorta are uncommon. Although if you had a dissection, then all bets are off. You could get aneurysms in any of those segments if you already had an aortic dissection. But in those patients with an intact aorta, you don't routinely see aneurysms involving the rest of the aorta. We'll briefly talk about how about dissection in those segments. So if you look at one of the natural history studies that was published in the Annals of Cardiothoracic Surgery, in this particular study, they looked at 78 patients with Marfan syndrome and aortic root dilatation, and they looked at them retrospectively to see what's the mean annual growth is. It's about 0.2 to 0.13 to 0.35 centimeters on an annual basis. But if you look at the diagnosis, if the patient is diagnosed at a larger aneurysm size, they tend to grow faster, particularly if they're already at more than 6 centimeters. And in mean age of onset of aortic dissection, this particular retrospective cohort was about 36 years. In general, there is a sharp increase in the risk of complications when the diameters exceed more than 5.5 to 6 centimeters. So that's how the current guidelines suggest beginning to operate at 5 centimeters or greater. So what can we summarize with the natural history? So the expected average increase in the aortic root in children who are on medical therapy is about 0.5 to 0.8 millimeters, but sometimes it can be as high as about 3 millimeters. The mean aortic root growth is lower in adults, about 0.3 to 0.7. Again, men and those with a larger aortic root at baseline tend to grow faster. And again, rates, if the patients are already on treatment, then they generally tend to grow much more slower. That's the idea behind medical treatment. So what are we trying to prevent? What are the most feared complication of an aortic aneurysm in patients with Marfan syndrome? And so this picture basically shows the different types of dissection. And there are 2 different classification systems that are used to define dissection. Most of the patients are familiar, and most of the providers are familiar with the Stanford classification, which talks about type A dissection, where the dissection with the tear in the aorta starts from the ascending aorta, and then it kind of extends throughout the entire rest of the aorta. Sometimes the dissection is limited to only the ascending aorta. That falls under the DeBakey classification of being a type 2 ascending aortic dissection. And then you have a type B dissection where the dissection does not involve the ascending aorta, but it tends to start beyond the left subclavian artery. That is the type B dissection. And if it extends only to the descending aorta, then it's type 3A. And if it extends from the descending thoracoabdominal and the abdominal aorta, then that is called as a type 3B dissection. So this is a surgical picture that Dr. Roselli had shared with me. So this is the patient with an intact aorta, with an aortic root aneurysm who is in the operating room getting an elective repair. Look at this aorta here. This is an angry looking aorta. This is a patient with an aortic dissection who came in for an emergency surgery. And our goal is to prevent this from happening and to address the root aneurysm before they progress to this particular significant and serious complication. So aortic root size is used to determine the timing of the prophylactic repair to prevent an acute type A dissection. On the other hand, type B aortic dissections those dissections that affect the descending aorta beyond the left subclavian artery can occur with little or no enlargement at the site of the descending aorta. So in general, avoidance of isometric type exercise and treatment with beta blockers and angiotensin receptor blockers have played a role in decreasing the risk of type B dissection. What are the risk factors that we know as things stand is if you had a previous prophylactic surgery of the aortic root and ascending aorta, it seems that there is some increase in those patients getting a type B dissection. Again, it's not uniform, but it's been reported that those patients could be at risk for dissection, partly relating to the abnormal flow patterns that could be generated by the surgical graft. How about the larger descending thoracic aorta? If it is already more than 2.7 centimeters, then that also has been noted as a risk factor. Or if the patient has an additional dilatation of the pulmonary artery, that also tends to be seen in patients with type B dissections with relatively normal descending thoracic aortic dimensions. So that's all I have for you. And thank you so much for your attention. And I am happy to answer any questions.
Thank you so much for that overview. Turning up my video back on here. We do have a couple of questions. Somebody is asking if you could just briefly clarify again the difference between a dissection and an aneurysm. So, like for example, this person's doctor said that her aorta is 4.5 centimeters. Does that mean an aneurysm or dissection?
Yeah, so aneurysm basically means that there is an enlargement of the aorta. So that's anything larger than what it's supposed to be for that particular location of the aorta, whether it is, there are different normal diameters at different parts of the aorta, whether it is ascending aorta, aortic root, arch, descending, abdominal. If the size of that particular segment is about 1.5 times the expected diameter, based on age and gender, that's when we begin to call it to be an aneurysm. For instance, in general, the easiest way I think about it is if you're more than 5 centimeters in the ascending, more than 4 centimeters in the descending, and more than 3 centimeters in the abdominal, that generally is accepted as aneurysmal. So it means that it's larger 1.5 times the expected. Again, there are certain semantics to that, but if you think about that, so whether 4.5 centimeters is an aneurysm, again, some institutions would call it to be as dilatation. Others would say anything more than 4.5 for ascending should also be called as an aneurysm. So dissection, on the other hand, is an acute emergency. It's not something that is diagnosed as an elective thing that you go in for a scan and the aorta is larger. That is not dissection. Dissection is an unmistakable event where patients tend to present with significant symptoms of chest pain, back pain, sometimes abdominal pain, or pain radiating into your neck, just purely based on the aorta picture that I've shown you with the branches coming off of the aorta and the extent of the normal thoracic and abdominal aorta. Does that answer the question?
Yes, I think that was really helpful. Thank you so much. There's a few other questions, but I think they're going to be answered by some of the other speakers. So I think we're going to thank you for your time this morning and answering that particular question and the overview, which really set us up great to start with. Thank you. Our next speaker is also from Cleveland Clinic, and that's Dr. Desai, and he's going to talk about imaging recommendations. So Dr. Desai, welcome you back.
Thank you. It's not letting me open my my videos.
Oh, let me try to help you there. That's strange. You were on before, so let's see. How about now?
Yeah, let's find out. There you go.
There you go.
So let me get can you see my screen?
Yes, I can. Not yet. It says that you've started screen sharing, so wait for your slides to pop up there. You just select them. There you go.
You good?
Yes, just slideshow, and then you'll have the whole screen on there.
I thought I was a slideshow.
There you go. All set.
Perfect. All right. Thank you so much to the Marfan Foundation as well as IndoUSRare for inviting us. And again, sincere thanks for your longstanding partnership with the Cleveland Clinic. I'm Milind Desai, and I will continue further on the groundwork set by Dr. Kalahasti with regards to imaging. So I'll start with this case. A 23-year-old female presented for an initial evaluation for a dilated aortic root, known gene-positive Marfan, prior history of mitral valve prolapse, status post repair a few years ago. She had spontaneous and recurrent pneumothorax requiring a right lung partial lobectomy. Patient has pectus carinatum. As would be expected, patient is interested in getting pregnant and was wondering about elective aortic root repair prior to pregnancy. The rest of the exam and medication is essentially unremarkable, other than the typical features of Marfan. So, as we look at the data, this is her cardiac MRI performed 2 years prior, where the root was measured to be about 3.9 centimeters. Images on the right side is the patient's CT, which measures a root of 4.5 centimeters. And the echo does show the mitral valve repair working appropriately and a slightly prominent left ventricle. This patient, after a fair bit of shared decision making, the patient has reached a root of 4.5, was 3.9 before, so progressing in the wrong direction, and was evaluated by one of our cardio-aortic surgeons and underwent valve-sparing aortic root replacement, which was done successfully. She did well. And she's doing well. This is the images after the valve sparing root replacement, which the root is now replaced by a surgical graft and looks pretty darn good. So with that as a setup, what are we talking about? Imaging in the context of Marfan syndrome. What are some of the imaging techniques we can use? Echo, which could be surface echo or transesophageal echo, contrast enhanced CT, and MRI. Why do we use it? To make the initial diagnosis of aortopathy as well as concomitant valvular diseases, to look for other systemic lesions, potential complications like Dr. Kalahasti mentioned, acute aortic syndromes, as well as for postoperative follow-up. So, as has been mentioned, the cardiovascular manifestations of Marfan are important to diagnose because they drive a lot of morbidity. They drive a lot of complications. So aortic root aneurysm and dissection diagnosis is key. Aneurysms can occur essentially anywhere, but most common area is the root. And it is absolutely important that the measurements are made accurately and in a consistent fashion. And so what my intention is, especially for the patients, is I want to make you a highly informed consumer. And the customer is always right. So you need to, when you look at your reports, when you look at your imaging data, there are certain things you have to be aware of. So echo is the first line, echocardiogram is the first line in the assessment of aortopathy. Basically, what we do is there are set criteria according to the guidelines how you should be measuring it. And it is important that the lab that is doing the measurements is doing it right. Now, a few things, okay? In younger kids up to 15 years, you can measure something called a Z-score. So any child with Marfan syndrome, I'm sure you know what a Z-score means by heart. Between 20 and 40, again, you can potentially use Z-score. And over the age of 40, it becomes a little bit more dicey, in my opinion. But Z-score has been an established way of assessing aortic dimensions. However, what are some of the problems with the Z-score? This is derived from transthoracic echo using diameters, not area. Your root, your aorta could be eccentric. It is not always a circle. In adults, Z-score are only available for the root and not for the ascending aorta. Body surface area, especially in the era of Ozempic and Mounjaro, can be changed quite frequently, and it may not be the most accurate. So my recommendation is, if you are a Marfan's patient or a patient with aortic aneurysm, every world-class aorta deserves a tomographic scan. That's the way I look at it. So gated contrast enhanced CT angiography. Every word here is important. A CAT scan is universally available and quick. It can image up to the full extent of the aorta, including branch vessels. Gating. What does gating mean? The gating means the scan is triggered at a certain part of the ECG, the heartbeat. Okay? You don't just keep the scanner open throughout. You instruct the scanner to measure only at certain parts of the heart, of the cardiac cycle, which ensures that there are no motion artifacts. So these are good CT examples of patients with measurements. CT scan, one protocol does not fit all. So depending upon where the clinical question is, if your question is within the heart, close to the heart, then you do a gated CT of the chest. If you want to look at the abdomen, you look at the abdomen. There are protocols when you can look at the full picture and now the modern scanners are sophisticated enough that you can get a scan done in a few seconds, a high quality, accurate scan. Measurements. I alluded to the fact that measurements of the aortic root and sometimes ascending aorta, they tend to be eccentric. And we have shown, Dr. Swenson, myself, Sagar, Kalahasti, we have shown in a large population that if you measure the area rather than a diameter and index it to your height, that is a lot better in terms of long-term prognosis assessment than reporting simple diameters. Diameters tend to be very prone to mistakes. These are a couple of things that, as an imager, I have to pay attention to a lot. The two images on the left are of the same patient who was transferred to the Cleveland Clinic because the local emergency room thought they were having a dissection. As it turns out, this is just a motion artifact. Repeating the scan, the second image on the left panel clarifies that you do not want to be this patient whose chest is cracked open because of a motion artifact on a CAT scan. The second image panel on the right side is there's sophisticated ways how we take the three-dimensional data and do the measurements. If you measure it the wrong way, your aorta measures 120 millimeters, 12 centimeters. That's not really conducive to life. But if you reconstruct it the right way, then the measurement is not that severe. So when we are making decisions about sending patients for heart surgery, this is absolutely the most crucial part of our job. MRI can also be used, and it can substitute for CT in some scenarios, but the studies have shown that it is also sensitive and specific comparable to CT. However, MRI tends to be a little bit more labor intensive. There are slightly more artifacts, and if you have patients with pacemakers or defibrillators, sometimes the images are not very optimal. So CT remains the gold standard. Echo is the first line, CT remains the gold standard, and MRI serves as a backup. Some of the orthopedic signs Sagar talked about, but as you are evaluating the scans, you will see those, including pectus, including the heart moving to one side of the body or the other, one side of the chest or the other. You will see some orthopedic abnormalities. So things you have to keep an eye on. So how does imaging help guide surgical timing? basically, if you have Marfan syndrome and a diameter of your aortic root more than 5 centimeters, surgery is recommended. If you have an aortic root of more than 4 centimeters, but high-risk features of aortic dissection, including family history, rapid growth, diffuse dilation, or highly tortuous vessels, these folks are also recommended to undergo surgery. Another new indication in the recent guidelines is if you do a cross-sectional area, similar to what I was talking about a few minutes ago, and then index it to height, and if your number is more than 10, then it is also recommended to undergo operation, especially if it is done at a highly experienced center like the Cleveland Clinic. It is recommended that by an experienced surgeon, a valve-sparing root replacement, especially if your aortic valve is okay, should be done. So acute aortic syndromes, again, this picture was shown. You do, as a patient, you do not want to find yourself in this situation. But if you are in this situation, what are the things? Obviously, CT angiography is the fastest and the most commonly used way to do this. It helps us identify whether the dissection involves the root, the type A. Does it involve past the neck vessels or type B? Is there not a tear, but just a hematoma bleeding into the wall, otherwise known as intramural hematoma? So CT is absolutely excellent, and you obviously need contrast for this to be able to make a highly precise diagnosis, and very fast. Transesophageal echo often is used. We use less and less of this, but this is a patient who presented with shock in the ICU, and the TE, the first shot, shows my arrow is talking about the aortic valve, and this is a dissected flap. Basically, this is in a highly emergent situation. You get out of Dodge and send the patient to the to the operating room as soon as possible. Now, another important role, you had your aortic aneurysm repaired. God forbid you had a complication and you've undergone a repair. Imaging, especially CT scan, plays a huge role. And depending upon the type of operation done, so if the surgeon kept the aortic root intact but put a Dacron graft in the ascending aorta, then you have to tailor the CT and look at the complications at the proximal and distal anastomosis. Sometimes the valve is messed up and you replace the whole thing. It is known as a Bentall procedure. Here you have to worry about not only the distal anastomosis, but how the valve functions, and also the surgeon will be reimplanting your coronary arteries. So are the arteries patent? So the CAT scan report has to be tailored accordingly. So you, the consumer, the informed consumer, should also be aware of all these things. David procedure, this is the valve-sparing root replacement where your valve is kept intact, but the root is replaced by a graft. Here you have to worry about the coronary arteries. You have to worry about the valve functioning appropriately, as well as the distal anastomosis. Now we are pushing the envelope, not just fixing the root and the ascending aorta. We are doing all kinds of advanced procedures, including something that is pioneered at the Cleveland Clinic called the Be Safer procedure, where we can do a hybrid procedure where you're doing a graft replacement of the ascending aorta and also putting a stent graft in the distal aorta. That requires specific type of tailored imaging and looking for specific different types of complications. So bottom line is, as the surgical procedures get complex and sophisticated, so does imaging. So to conclude, imaging is crucial for initial diagnosis, therapeutic planning, as well as follow-up. Echo and tomography are crucial. Aortic root and aortic dimensions have to be measured consistently and without free of motion artifacts. And in acute aortic syndrome, quick, accurate, artifact-free and confident diagnosis is crucial. And as I alluded to, tomography is important for long-term follow-up. Thank you so much, and I'd be happy to answer any questions.
Thank you so much, Dr. Desai. It's just clear you love what you're doing here, and thank you for that great presentation. We definitely have some questions for you. First question, are there clinical criteria in terms of aortic measurements for when a child should be put on a beta blocker or an ARB to prevent aneurysms and slow the aortic root dilatation?
So I will start by saying I'm not a pediatric cardiologist and I do not see pediatric patients, but there are trials that have shown some promising data in the context of ARBs that help potentially slow the progression. My recommendation is you discuss with your expert pediatric cardiologist about the timing of when you need to initiate medical therapy on your child.
Okay, thank you. I know you talked a little bit about when you need to get somebody right to the OR. Somebody is asking, what advice would you give a person whose aorta does not yet measure 4.5 centimeters? Like, how often should they follow up imaging and they want to obviously prevent emergency?
Exactly. So guidelines do recommend, especially in Marfan syndrome, if you are more than 4, but knocking the doors of 4.5, I would say at least every 6 months is important. Number one, sometimes your physician may want to do it a little sooner. The other important thing, obviously, is lifestyle modifications. And I understand there's a talk on exercise and weight restrictions, so I will not steal the thunder. But clearly, what needs to happen? So what I tell patients is as follows. Number one is you need to have precise measurements. Number two, you need to recognize where you're going to have your elective operation, which center, which surgeon. You don't go shopping for a surgeon once your aorta, knowingly shopping for a surgeon once your aorta reaches 5 centimeters in the setting of Marfan. And what I tell patients is, if let's say you chosen Cleveland Clinic as your facility, then you need to have your serial imaging follow-up done in a uniform manner, likely at the center where we are going to operate, so that we have all the longitudinal data. Me and Sagar read CTs along with almost 24 of my colleagues, and we do it in a very systematic, uniform way. And we have a way of going back and looking at as many images as we want to. So I think that is absolutely important. Have a game plan of what you're going to do. And look, to me, the way I talk about it is as follows. If you are a known Marfan's patient with a growing aorta, I have not done my job if you somehow, if I do not talk to you about a planned operation and set a date once you reach a certain threshold. There are some unique situations. So, for example, me and Eric Roselli always talk about, some unique situations of not just Marfan's, but dilated aortas. In unique situations, we talk amongst ourselves and decide we are going to wait for the aorta to reach X, 4.4, 4.5. There are times when we have taken people at 4.4, a short person or what have you, with a glaring family history. But we have a game plan in our minds. It's documented. We tell the patients so that everybody's on the same page.
Yeah, that's great advice. I mean, that really speaks to the whole point about getting your care at centers where they have a lot of experience and expertise with these conditions. So thank you for that. And one more question, how safe or what are the risks of having a CT angiogram every year? This person says that she prefers an echocardiogram, but her cardiologist insists on a yearly CT, but she's afraid of the excess radiation and plus it makes her feel sick. So what are your thoughts?
So the thoughts are as follows. I alluded to the echocardiographic, the challenges of echocardiography. If the measurements track with CT on a consistent basis, that's good. But often you are measuring a diameter, not an area. You do not have three-dimensional assessment, and it is prone to to not so accurate measurements. Having said that, in 2025, the CAT scan technology has gotten extremely sophisticated to a point where we can do a gated CT of the aorta at a very low radiation. So, if you come to the Cleveland Clinic, your radiation dose is going to be significantly lower compared to if you go to a less experienced center where they are not paying diligent attention to detail. Having said that, another possibility is do an MRA, cardiac MRI, which can provide, to me, in terms of hierarchy, CT is more accurate than MRI, and MRI is a lot more accurate than echo. But if I'm in a pinch and if I have to choose between, I cannot have a CT, then I would recommend an MRI.
Great. Thank you so much. We appreciate your time today and getting into the nuances of all this and answering questions. There's a lot more questions. Some of them are about surgery, so we're going to save that for Dr. Sultan, who is up next. So thank you so much, Dr. Desai. It's great seeing you here. And I'd like to invite Dr. Sultan to come back. So now I'm pleased to introduce Dr. Ibrahim Sultan from the University of Pittsburgh Medical Center, another center that works really closely with the Marfan Foundation. And we're so excited for all the activities going there. They've got a great aortic center, really committed to people with Marfan and other genetic aortic and vascular conditions. So Dr. Sultan is going to address options in aortic surgery. I see a lot of questions for him. So if you have additional questions, wait until he presents, and he may be answering those questions during his presentation. So thank you so much for being here.
Great. Thank you so much for the kind introduction, and thank you to the Marfan Foundation for the kind invite. So my name is Ibrahim Sultan, one of the heart surgeons at University of Pittsburgh Medical Center. Here are my disclosures. I should also disclose I'm not from Cleveland Clinic, so you'll get it perhaps slightly different view, but it was great to hear the last two speakers talking about how things are done. And quite frankly, I think I love the passion with which it comes out, because, I feel just as strongly about a lot of the points that were made when it comes to imaging. So your patient or loved one needs aortic surgery, and you may have genetic inherited aortopathy or some sort of aortic syndrome. So what are your options, right? And so I'd say, first of all, do your homework, right? So you go to the internet, you Google, and you will see a battery of hospital websites that will sponsor and put things on Google about, this is where you need to go get your heart surgery, et cetera, et cetera, et cetera. But do your homework when it comes to what is it exactly that particular organization or surgeons or cardiologists do. Use resources such as the Marfan Foundation that can help guide you. Say, you know what, you live in this particular area. These are the 2 or 3 hospitals closest to you. This is the hospital and the surgeon that has the most experience. This is the hospital that may have the best outcomes. This is the one that may give you the best support. And, always have a plan. I think the last couple of speakers pointed this out. It is entirely different when you need elective surgery. Shop around. I mean, the reality is, I think in this world that patients, and I hate the term customers and consumers it was used, but patients look at it as consumers and customers, and use the information. Always have a plan. Go see who you need to see, and get multiple opinions, because in the end, this is very personal, right? Surgeons like ourselves, we do 2 to 3 of these operations every day, 4 or 5 days a week. For you, this may be a one-time thing or a 2-time thing in your lifetime. And how your operation goes affects the rest of your life, and not just your life, your loved one's life. So really take the time to think about it. And then have a backup plan, in the sense that what are you going to do if you have an aortic dissection? Because then the mortality for an elective aortic operation, if you need an elective aortic replacement or ascending aortic replacement, is exceedingly good at most centers. It is close to 0%, less than 1%. It is interesting, this was talked about, how an aortic replacement mortality is just as low as an aortic valve replacement mortality in the Society of Thoracic Surgeons database, which to me is mind-boggling. But when it comes to thoracic aortic dissection, that is where you will see a huge difference. So have a plan if your aorta were to dissect, what hospital you'd want to be at. Okay. Now, what matters? The institution of the hospital matters, and the surgeon matters, but more importantly, I would say the surgical team, which means the anesthesiologists, the critical care docs, who are taking care of it in the perioperative setting, and your personal and family support, meaning that, if you're traveling, quite frankly, hours to get to a particular hospital, you'd have no support. That's going to be a little bit challenging than staying perhaps closer to home. And this was covered. When should you see a surgeon? When you and your cardiologist think about, when you're getting close, don't meet your surgeon after you've gotten there. And when you need surgery, start thinking about it before. And I see a lot of patients. I'm in the middle of my aortic clinic right now. And quite frankly, I saw 3 patients already who are nowhere closer to the threshold. The first time I'm seeing them, they don't really need to come see me. They're likely not going to meet indication for some time, but they wanted to know who I am, how I do my surgeries, what our outcomes look like, what our volumes are like. Very intelligent questions. And that is what I would encourage you all to ask. Now, a lot of times you may need other vascular surgery or mitral valve surgery, et cetera, when you have inherited aortopathies or Marfan. But when it comes to aortic surgery, most commonly you're going to need an aortic root replacement. You may have an aortic dissection, or you most likely need some level of reoperative surgery for your arch or thoracoabdominal aorta. And most of the times you're not going to have any symptoms. And again, having symptoms is extremely unlikely unless you have a dissection. And this is where careful and thoughtful surveillance comes into important. Now, the reason this is important is without intervention, without surveillance, without intervention, patients have a very limited life expectancy. And if you look at the dissection prevalence, it is degrees several times that of the degenerative aortopathy population. And this is important. So 2 things. Number 1, the thoracic aortic dilation is extremely high in patients compared to degenerative aortopathy or sporadic aortic patients. Similarly, the dissection prevalence is extremely high. So those are the 2 big reasons. The only exception to this, and if patients have bicuspid aortic valve, entirely different story. Patients with bicuspid aortic valve dilate fast, but there's no absolute data to prove that they have a higher risk of dissection. That has been proven false over time. Now, this is what an aortic dissection looks like when you're looking in the operating room. So your the patient's head's towards the bottom of the screen, feet are towards the top of the screen, and you can see this flap going back and forth. It's almost a paper-thin aorta. You can think about it. It looks so angry. You could look at it funny, and this could really explode at any time. And this is why patients can potentially die and rupture. So when do you need surgery? You will see a lot of numbers being thrown around, and you will see these numbers. These are guidelines, obviously. A lot of this comes from European and American guidelines, ACC/AHA guidelines, and ESC guidelines. But these matter depending on what you have. Majority of these are old. Some of these are based on retrospective data, but really no good prospective data to show that. But in general, if you have, for instance, I'll just pick Marfan syndrome. When you get to 5 centimeters, you typically want to get surgery done. And when you get to 4.5 and above, you want to start thinking about, particularly if you have a high-risk features. For a bicuspid aortic valve, sporadic aneurysm, entirely different story. Now, the threshold has lowered and lowered and lowered over time. Majority of the reason why, because us as surgeons say, you know what, we can do these operations with less than 1%, close to 0% mortality and stroke. The reality is that if that 0.5% or 1% happens to be one of your loved ones, that's 100% as far as you're concerned. So know those numbers. And it's important when you're thinking about prophylactic surgery, which is what this is, that when you want to get this done. Now, the common interventions are typically aortic root replacement, specifically valve-sparing aortic root replacement, which is the most common intervention that we see in patients with inherited aortopathies. And occasionally, just a simple ascending aortic replacement, which is uncommon in patients because we really want to have a comprehensive operation when we do this. Similar when it comes to the arch. We don't want to leave disease behind. We want to be as comprehensive as possible when we do this. And if the valve is not sparable, which is uncommon in patients with Marfan syndrome, then we can put an artificial valve in. And when it comes to that, and I'll talk about this later, know your valve choice. It is extremely important. Now, when it comes to extent of arch replacement, the last speaker spoke a little bit about arch reconstruction, and we tend to be very aggressive about this, doing a complete arch reconstruction, because this allows us to then serve as a scaffold for future intervention down the line. What happens here is the following. As soon as you have surgery for proximal thoracic aorta, such as aortic aneurysm repair, that level of stress that the heart is producing goes away from the graft to the rest of your native aorta, thus putting the rest of your native aorta at risk for thoracic aortic dissections. It almost increases the risk of dissection downstream and overall. This just gives you an example of how an operation is done. the head's towards the top of the screen, feet are on this side. This is just an aorta that's partially dissected. Again, we tend to be very comprehensive about how we do this, and we replace actually all the branch or the head vessels. This is the innominate artery that's going to be reconstructed with this again, native graft that we use here, typically in Pittsburgh, and have popularized. And we try to replace, again, the innominate artery, left carotid artery, left subclavian artery, and the rest of the ascending aorta arch the process. Now, as we're doing this, as you can imagine, the blood supply to your brain is partially interrupted. The blood supply to your body is partially interrupted when we do this. It is complex heart surgery that takes a few hours for us to do. And we want to do this carefully and thoughtfully without increasing risk of mortality, morbidity, and complications. This is, again, a totally atherosclerotic aorta, as you're seeing here. We're looking down. This is a patient who needed 2-3 stage operation. This is a frozen elephant trunk that we put down the descending aorta, which is essentially a stent graft that serves as a scaffold for the future. Again, a lot of cutting and sewing, but the bottom line is we want this to be absolutely watertight, blood tight, with absolutely no level of bleeding or pseudoaneurysms or issues down the line, which is what you're seeing here. Now, this is also very common, which we see in patients with Marfan syndrome and Loeys-Dietz syndrome. VETS, for instance, we see intussusception of the aorta, and this is us looking down the aortic arch where the aorta is intussuscepted. We're unfolding and unfurling it. So that is the level of dissection and what we're seeing from time to time. And as I said, you know, we have the world's largest experience with neuromonitoring these patients during surgery. Every patient who comes to us, we monitor their brain activity during the operation. And that is how we've helped reduce the risk of stroke over time. Because even if it's 1 to 2%, it is significantly high when we don't monitor these patients, we don't know what's happening to them over time. Now, you will hear this repeatedly. Volume, volume, volume. The volume outcome experience is real, especially when it comes to thoracic aortic pathology. The more of something we do, the better we get at it. And it's not just about the surgeon. It's about the entirety of the team that's taking care of you. The nurses, the anesthesiologists, the cardiologists, the critical care docs, everyone who's seen this problem over and over and over again knows exactly what to do when something goes wrong. When everything goes well, every patient will do fine. It's when things go bad, you want to be able to rescue that patient right away. Now, when we talk about why in different inherited aortopathies, what are we looking for? And a lot of these were covered in the last talk, so I'll go ahead and skip that. Another aspect, before pregnancy, if you're thinking about getting pregnant during pregnancy, this is an absolute important consideration to have. And if you're somewhere in the border, you know, there's a lot of conversation about potentially considering prophylactic surgery earlier. Again, this is all shared decision-making with your surgeon, with your PCP and your cardiologist. Think about valve choices when you're young. Again, there's a huge trend towards tissue valves, and in some patients, it may not matter because of limited life expectancy. But we know extremely well with very, very strong and high level of data that if you have a mechanical valve, your valve cannot be spared or saved, which is, again, a small percentage of patients, but it does happen. Getting a mechanical valve when you're young increases your life expectancy. So important consideration. There's multiple more things to think about, but just something to think in mind. Descending thoracic aorta, more complex operation, higher level of morbidity and mortality that comes with it. There's a lot of talk about stent grafts in patients with inherited aortopathies, but this is not something that has become mainstream. We have done this a lot, but again, with cautious optimism. The most standard, again, is doing a full thoracoabdominal aortic replacement in patients, again, as long as you're at a high center with experience. Now, surveillance is important. How you survey, again, be uniform about it, as Dr. Desai mentioned, be uniform about it. Try to go to the same place over and over again. Make sure if you're getting a CT scan that it is gated over time. So again, key take-home message, happy to take any questions afterwards. Ensure that whoever's taking care of you is a multidisciplinary aortic team. Make sure there's shared decision-making. If you're contemplating pregnancy or pregnant, those decisions become much more challenging, and really take your time as you talk about it. And most importantly, a lot of the catastrophes that happen are not when women are pregnant or during pregnancy, it's immediately afterwards. That is when the hormonal release changes the vasculopathy and leads to a high degree of dissection. I will stop there and happy to take any questions. Thank you again for the invite.
Great. Thank you so much for all that. I mean, the level of expertise and experience you have there, your point about volume could not be more important. So thank you for talking about that. That's really important. I'll just take a couple of questions for you. What are the recommendations for intervention regarding uncomplicated type B aortic dissection in Marfan What diameter? Does it need to be open surgery or endovascular work as well? Let me put
Yeah,
myself
I would say great question. Highly controversial. Let me start with non-Marfan patient. In non-Marfan patient, I would argue that this is still a controversial decision where treating patients with uncomplicated type B decision is not mainstream. The reason it is so popular now is because as soon as we have stent graft, this makes the operation very easy. Doing a thoracoabdominal aortic aneurysm replacement is much more challenging than doing a TEVAR. And I do both, and I can tell you that very frankly. So as soon as you have access to technology, meaning that you can put stent grafts in comfortably, everyone wants to do them because it's easy to do. So even a non-Marfan patient, and for an uncomplicated type B, it is not mainstream to treat all those. So I would say in Marfan patient, be even more careful about it and not jump into it unless you have high-risk features.
Great, thank you. We'll do one more since we're talking about things that are maybe not mainstream yet here. What's your opinion on the pairs surgery? Maybe say what it is quickly, and then what are your thoughts on it? Because somebody's asking about it.
So Duke Cameron talks a lot about this, and so does a lot of European folks. I don't have any experience with it. I think it shows a lot of promise. I think there's good data to support it. I would say that we have not adopted that, quite frankly, for certain concerns, because we think that there are different options that serve just as well with extremely good outcomes. So we have not taken this and taken this out as mainstream, but again, it's a very good option. And I would discuss that with surgeons who have specific expertise in pairs.
Can you just describe really quickly what that is, what pairs stands for?
Yeah, so pairs surgery, again, is a concept of an aortic root surgery. It's again a preemptive operation. So it's personalized external aortic root support. That's what pairs stand for. It's essentially a 3D printed mesh, right? So it helps to stabilize the aortic root. In the past, stabilization techniques have been used and don't have the same exact outcomes as reimplantation techniques in patients with aortopathies. So that's, I would say, the biggest concern we have. As data develops over time, I think we'll likely see better and better outcomes.
Great, thank you so much. And for anybody who's interested, there's definitely more on that on our website and our YouTube channel. So thank you for that question. So thank you, Dr. Sultan, for that presentation. Really great overview of aortic surgery. I know we can do like a whole hour or 2 hours on that, but thank you for that and for the images as well. It really brought it home.
Thanks, Eileen. Appreciate it.
So our next speaker today, we're going to go more into quality of life with Dr. Prakash from the University of Texas Health Science Center at Houston, another amazing institution that we've had a long relationship with. They do great work there. Houston's a hotbed for all medical situations, but they're really great in the whole connective tissue area. There's a lot of new information I know Dr. Prakash is bringing to all of you, and there have been some questions about exercise as well. So I will pass it over to him.
Thanks, Eileen. Hello, everyone. Good morning. Where we are, it is good morning, and afternoon or evening to all the rest of you. I'm sharing my screen now. So my topic is really focusing on exercise, but I'm also going to mention medications and quality of life. Essentially, these are things that you can do for yourselves on a daily basis that helps to maintain your aortic health and prevents the need for surgery and also prevents dissection. So these are the ways that you can empower yourselves to take better care of your aorta and also improve your mental health. So there's so many questions that people have about exercise. Here are some examples from actual patients in our clinic. So people are wondering, how can I remain active? I have this diagnosis. It's hanging over me. It feels scary. It feels like I might have to have an operation like the ones we heard. How do I keep going and really do what I like to do? What exercises do you recommend? I get that one a lot. And it would be followed by their specific situation. But in general, what is good for me and what should I avoid? And then after I had surgery, can I go back to doing things? And how long should I wait? And what kind of things can I now not do that I could do before? So these are super common questions, and they cause a lot of anxiety because people aren't getting always clear or consistent answers. So how safe is exercise for patients who have aneurysms or dissections? So we know from a long time ago, actually, that people with abdominal aortic aneurysms do really well, even with very large aneurysms. And it was shown that people who exercise regularly with abdominal aortic aneurysms, also known as AAAs, may even decrease the expansion rate of their aneurysms. We know that people who have cardiac rehabilitation after an aortic operation actually do pretty well. And there are three large studies of this in France, the United States, and Switzerland for people who were studied and underwent pretty intensive rehab after type A dissections and after open repair of aneurysms. So it seemed to be safe, and it actually improved their quality of life in many cases. And more recently, we have data on mice with Marfan syndrome gene mutations that you probably heard about. So they exercise these mice on a treadmill, like patients. And after a few months, they actually showed that it slows down the rate of their aortic disease progression. So these are all super encouraging. And that data was actually replicated a couple of years ago by Siddarth Tierney's group at Stanford, where they showed that individuals with Marfan syndrome, these are young adults and kids, who did more than 10,000 steps a day actually had decreased rate of growth in their aortas. So exercise is actually really good, and it's part of the therapy, the treatment for people who are living with aortic disease. This is important to emphasize because it's very different from the message that people were getting just a few years ago, and may still be getting in a few places, that you should avoid exercise because it puts too much wear and tear on the aorta. We think that it actually helps protect the aorta now. And we and others have done clinical studies to show that light to moderate exercises are safe in patients with all types of thoracic aortic disease, including aortic dissection survivors. And we're working on a multi-center clinical trial that is coming out later this year, where we actually showed that these patients do really well, and they also endorsed a higher quality of life after participating in an exercise program. So there are a few things that you should keep in mind, because there are important considerations when starting exercise. And this is true for a lot of people who might have stopped doing things or have been sedentary for a while and want to get back into exercise. So know your risk factors and health status. So one of the big ones that comes up is, what is your personal risk to have an aortic dissection? The answer is complicated, and it usually helps to have a discussion with your aortic health specialist about this. But in general, we know of a few risk factors that you can control that may decrease your risk. One, and the most important one that we know of, is high blood pressure, and I'll go into exactly what that means, but you should know if you have it and if it's well controlled. If you're smoking or vaping, you should stop smoking or vaping. That by itself is a huge decrease in risk. It also depends on your genetic information and family history, whether you have an aneurysm, as you heard, and how large it is, how close you are to needing surgery, if you've had previous surgery, and if you plan to become pregnant. All of those things can affect what you may perceive as an increased risk period in your life. And then it just means that you need to undergo a little bit more testing and care before you start exercising, and maybe a little more frequent monitoring during exercise. It certainly doesn't mean you can't exercise. So as we mentioned, the biggest controllable risk factor for people with aortic disease is blood pressure. So you want to know, is your blood pressure well controlled before you start exercising? Because that is a major risk that can change with exercise, as we'll talk about. And this means regular checkups with blood pressure checks and medication adjustments. So either by your primary care provider, by your aortic specialist, or ideally both. You should be also keeping an eye on your blood pressure at home. I tell all my patients that they should check their blood pressure at home. They should know roughly where they are in terms of their blood pressure control, and be able to send messages if they feel like their blood pressure is increasing or going out of the target range. And then, of course, it's important to know if your aorta is changing. Are you getting close to that threshold of needing surgery if you are being followed for that? Do you feel like your disease might be changing? And that can influence the likelihood, again, that you may need a procedure in the near future. And sometimes it may not be the best time to start an exercise program if someone is talking about doing an operation. And this, of course, means you need to get regular checkups with imaging of your blood vessels, as we've heard in the previous talks. And then finally, how is your mental health and quality of life? what we have and others have shown is that people who stop exercising often have severe anxiety and depression due to the withdrawal of things that they really love and that they love doing. Exercise. So taking an inventory of these things really helps you define your priorities and understand what you need to do to keep yourself safe. So again, before starting exercise, it's really important to make sure that your blood pressure is controlled. This is from the guidelines. We typically say, you know, for high blood pressure, the top number needs to be less than 130 and the bottom number over 80, but really 120 over. That's what we target for everybody with thoracic aortic disease in particular, because we've shown that any numbers above this can increase the rate of enlargement of aneurysms or predispose to dissections, and also prolong recoveries after surgery on the aorta. And so the two kinds of medications we recommend are ARBs, or angiotensin receptor blockers, which you probably have heard of, like Sultan, and beta blockers like metoprolol or atenolol. Many patients with Marfan syndrome and related conditions are prescribed these. We consider them lifelong medications for several reasons. And a recent clinical trial had shown that there isn't a huge difference in Marfan syndrome on their effects on the aorta. Both of them seem to be about equally effective. So the choice between the two comes down to a few practical things that we go over with our patients. But really, there are things that favor being on an angiotensin receptor blocker and things that favor being on a beta blocker. And it's an individual patient decision at this point based on the data that we have. And so typically, we will do a 3-week trial of a new medication. If we're putting a patient on something they've never taken before, we ask them to log their home blood pressures before and after starting. And we recommend some blood tests if they're on specific types of medications because they can affect their kidney function. So this is a kind of a shared decision-making process with people. So the key points to remember about medications is you need to know where your blood pressure is sitting at any given time, both the highs and the lows. So checking it at home is really important because in clinic, we can't only see it at one time. You want to target a systolic blood pressure of less than 130 and ideally around 120 or less. Beta blockers or angiotensin receptors are first-line agents, and this choice depends upon many different factors that you can talk to your doctor about. And these are not just for blood pressure. It's important to remember that these medications have independent protective effects on the aorta. They can prevent dissection, they can prevent aortic enlargement independent of their effects on blood pressure. So these medications are for life, and even after surgery, you should continue to take a protective medication, particularly with a condition like Marfan syndrome, where we know the entire aorta is at risk for dissection. So the other thing to consider is that the type of exercise that you do affects the way your blood pressure responds to exercise and your aorta responds to exercise. So we talk about isometric or isotonic exercises. This is where you're contracting muscles without moving them. You can think about like lifting heavy weights and straining to do that. Well, your systolic blood pressure is going to increase in the proportion to the percentage of your body weight that you lift. And this is where a lot of these prohibitions about specific weights, amounts of weight that you can lift come from. But there is, in fact, no basis for specific weight limits. It really has to do with your strength and condition in terms of how much you can lift without straining yourself. The increase is sudden and short-lived. And it's very difficult to really understand how systolic blood pressure in particular varies during these kinds of maneuvers because it really depends on the technique that you use to do the thing like weightlifting and how conditioned you are, as I mentioned. There's a limited opportunity to adjust the intensity of the exercise before you reach this peak blood pressure, and it's unpredictable. So that's why we often see limitations on things like weightlifting for people with thoracic aortic disease. The other main type of exercise that you may know about is aerobics, like running. The systolic blood pressure increase in these conditions is gradual but more prolonged. It can be readily measured during exercise, as you might think about a treadmill test that we sometimes do put patients on for a variety of reasons, but we can measure blood pressure while they run. It provides an opportunity to adjust the intensity of exercise before you reach a high blood pressure reading. And the increase may not be predictable from your resting blood pressure. So in other words, you can have a normal resting blood pressure, but you can develop high blood pressure during exercise. So for this reason, we sometimes observe patients while they're running to make sure that their blood pressure stays low. So this is kind of a graphical version of this. On the left, this is dynamic or aerobic exercise. Your blood pressure gradually peaks and then plateaus, remains a little bit high after you run and then falls off. Isometric exercise, with each repetition of weightlifting, your blood pressure will go up quite dramatically and then fall back down. And sometimes these could be very large changes in blood pressure. So those are the things that we kind of want to avoid because they put a lot of stress on the aorta, as you can imagine. So there are really three types of high blood pressure that we're talking about when we talk about aortic disease. One is the condition of your aorta and blood vessels. So in other words, what kind of blood pressure do we think your aorta can handle? Is it very thin? Is it damaged? Your day-to-day or ambulatory blood pressure, like what is your walking around blood pressure and what is your blood pressure doing during exercise? So the total risk due to blood pressure is really all three of these, and we really need to be measuring and pay attention to these when someone starts to exercise. Now, because of this, there have been physical activity recommendations by the Marfan Foundation that you can look up, but a lot of them talk about avoiding very intense exercise, very prolonged exercise to the point of exhaustion, or these isometric activities for those very reasons, to try to avoid these spikes in blood pressure. So during our clinical trial, we found that people did generally very well, but the number of kind of problems they had during exercise seemed to be directly related to the number of blood pressure medications, in that people who were on more blood pressure medications seemed to get a little bit more lightheaded and dizzy during exercise. And this is a natural response to side effects from medications. It's not related to the aorta itself. And so fortunately, we think that this is controllable. We also found that the people who ran into more problems during exercise had fewer minutes of training per week, as shown in this slide. So if they felt lightheaded, dizzy, or had palpitations, they were more likely to have spent about half the time exercising when they participated in a physical activity. So this suggests that there's a training component that you have to ramp up gradually and build up to what you're capable of. So our studies have shown that athletic activity after diagnosis is possible. There are even people doing competitive athletic activities. These are not officially sanctioned, but there are things that we hear about from our patients and have surveyed them. Up to 20% of people who did endurance activities like running experienced minor health episodes relating to fainting or dizziness. And we think that these can be prevented by increasing conditioning and strategic changes to your cardiovascular medications in consultation with your doctor before you start a more intensive exercise program. So our practical advice: get yourself checked out before you start an exercise program, especially if you have been inactive for a while. You can lift whatever weight you can comfortably lift without having to bear down. That's that Valsalva maneuver that you might have heard about. And isometric exercises, where you really contract muscles without moving, are things that you should probably avoid if possible, because these actions increase pressure on the aorta. We recommend light to moderate aerobic exercise on a daily basis, at least 2.5 hours per week in total. And of course, there may be difficulties using heart rate to monitor your exercise if you're on a beta blocker, because they lower your heart rates. So we recommend using a rating of perceived exertion, or Borg scale, which I'll go into in a minute, instead of heart rate, to monitor your exercise intensity. Do not exert yourself to the point of exhaustion, and of course, ramp up slowly. So this is the rate of perceived exertion scale. And essentially, it's your own personal scale, where 1 is the lightest activity you can imagine doing, sitting on your couch, raising your leg, and 10 is the maximum effort you can imagine doing. You want to be in this 4 to 6 range. And that's going to be different levels of activity depending on your individual fitness and experience. But it is we have shown that it's a reliable indicator in terms of moderate and vigorous responses to blood pressure during exercise. And then finally, this is not exercise, but practical important advice, because a lot of us have musculoskeletal problems. Avoid chiropractors for neck and upper back pain, because manipulation of these, the neck and upper back, can damage arteries in the neck, especially if you have existing aneurysms there. And then use caution when cycling or squatting, particularly if you have iliac artery aneurysms or dissections, because these can be damaged by the pressure related to these activities. And finally, I tell everyone to be concerned about constipation, because straining with bowel movements is another example of the Valsalva maneuver, and using stool softeners and remaining well hydrated is a way to avoid this. And thank you.
Thank you so much, Dr. Prakash. We do have a couple of questions. We'll try to, I mean, we're running out of time, but I do want to ask you a couple of them.
Sure.
We have somebody on who is 28 years old with Marfan and says he's fit. He's going to be going to Machu Picchu. So he's wondering, does altitude pose a higher risk for Marfan syndrome patients?
Yeah, so as I mentioned, a lot of Marfan patients are going to be on medications. These medications are associated with symptomatic episodes, and particularly if you're changing altitude, the most important thing is acclimation. Acclimation is super important if you're doing any kind of exertional activity. Generally, up to 72 hours is what they recommend. I say at least 48 hours at a high altitude, because you're going to need time to acclimate to that extreme difference, particularly at that altitude, before you do any kind of physical activity. And of course, pacing yourself is very important. There is nothing intrinsically otherwise different about the risk related to altitude changes in in this situation. But just using practical common sense, remaining hydrated, and being cautious.
Great. Thank you so much. There's several other questions. I think you covered a lot of them. So we are going to take those just to make sure we get them answered. And if our help center can't do it, we will definitely reach out to you. And if anybody has additional questions on this topic, definitely submit them to marfan.org/ask, and I'll put that website up shortly. So thank you for your time this morning. We appreciate it. Now, to put it all together, we have a very unique situation here where we're going to, we like to share personal perspectives, because, you hear from the doctors, but what's it like really living with this, and what has somebody gone through? What has helped them? So our next speaker is Dr. Adam Haniff, and he's a doctor, as it says there. He's at Cleveland Clinic, but also he has Marfan, and we've known him since he was a young one. Kind of grew up with the Marfan Foundation. So I'm going to give him a few minutes to share his story a little bit with his unique perspective, both sides of the coin, and hopefully that will help some of you as you're navigating your journey. Adam?
Yes, thank you so much, Eileen. Like Eileen mentioned, my name is Dr. Haniff. I'm a physical medicine and rehab physician at the Cleveland Clinic, and then pursuing hospice and palliative training at the University of Michigan next year. I'm a disability expert and a quality of life expert. That's what the medical specialty is focused on. But a bit about my story. I was diagnosed when I was 3 years old. I had a lot of the ocular manifestations, ectopia lentis in both eyes, that tipped off my ophthalmologist that I may have a connective tissue disorder. And then after having an echo when I was 4, had an ascending aortic aneurysm. I had my aortic surgery my 3rd year of medical school, and then had some retinal procedures my 4th year of medical school. And throughout the whole journey, the Marfan Foundation has been a key part of keeping me informed and educated about all the different surgical options, also knowing in my specific community what resources were available for me. The Marfan Foundation, it has chapters in all different parts of the country, all different parts of the world, and has their yearly meeting as well, where they review all the latest literature, all the latest things that are being discussed by the aortic professionals and medical professionals all across the world. When I was first exposed to them, we knew nothing about Marfan syndrome. Nothing. We were the only people in my community that knew that we had Marfans. And navigating just the public school system, professional education, accommodations in your workplace, accommodations at school. Those are all things that you're only going to find out about if you're connected with a community like the Marfan Foundation, that can put you around a like-minded community that are all facing the same types of existential issues, the same types of medical complications, and they'll be able to give you a much broader perspective about living with this condition. And so when I was 13, that was when I went to my first Marfan Foundation conference, and I've been with the different aspects of the foundation ever since. They're the reason why I chose a career in medicine. I was exposed to, his name was Dr. Hal Dietz, and he'd had a informational session with some of us, and we went over all the latest research, and it was absolutely one of the most inspiring moments for me when he was talking about at that time there was a big discussion about ARBs versus beta blockers. It was before the big study came out, but after we had discussed it for a long time, he was like, yeah, we need more medical providers that are out there that are going to focus on the quality of life and parts after the surgery. And that was something I would have never considered myself doing if I hadn't been around a community of people that could inspire that kind of, that could inspire me in that way. So kind of the conclusions of everything, the community that you're a part of is a huge resource, and they can fill in a lot of the gray areas that the medical community won't be able to fill you in on. For example, family planning or career decisions or returning to work after your surgery. After your surgery, how does rehab look? Are you going to a cardiac rehab facility? What does cardiac rehab look like? Does the hospital that you go to, are they in partnership with a cardiac rehab facility, and are they able to seamlessly transition you after to make sure that you're able to go there? How does insurance work? Those are all things that you want to make sure that you're with a community of people that have been through it, have seen kind of the things that you're going to go through. And there's no better organization than the Marfan Foundation to help facilitate that with you. They also have lots of different surgical centers that they go through and try to find those aortic centers of excellence. And those places are the facilities that if you get partnered in with early in your diagnosis, your outcomes are going to be a lot better. There's a lot of literature about the surgical outcomes, but also just connecting all the other parts of for your quality of life, your follow-up after, and those are all very, very important parts. So I just wanted to come on and share a little bit about my story, how the Marfan Foundation has been instrumental in my success. And I hope all of you, there were a lot of really great speakers today, speaking about a lot of different things that really over the last 10 years, the field has changed so much. The surgical expertise is incredible. Life expectancy has increased by so much. So now to shift that gear from some of the surgical parts to the things that impact your day-to-day living, that's going to be where having that community of people that are able to be that guide for you, that's going to be instrumental in your success.
Thank you so much, Adam. I didn't really invite you on here to talk about the foundation like that, but we appreciate all the kind words. I do have one question for you. There's a lot of parents on this call, and we get these questions all the time. And you talked about the importance of community. Every family is different, and we completely respect that. But what I want to know from you is, like, what advice would you have for parents of a child with Marfan, whether they're a child or a young teen or a teen who is hesitant about being part of the community? And sometimes they say to me, should I bring them to the conference? They don't want to come, or they don't want to get involved in this or that, whether it's local or whatever. So as somebody who kind of got into this as a young teen, what are your thoughts? Again, every family is different, and we respect that. But what would you say to those parents who are not sure how to handle that situation with their kids?
Definitely. And I'll be the first to tell you, when my parents told me about the first conference in Boston, I was very hesitant. I was like, I don't know if they're going to, my relationship with the medical information, it was a more bleak picture. So I was like, I don't know if I want to be around a community of other people that are all going through it like I am. But that's the thing that I have to say. It's you only know, you don't know what you don't know. And once I was there, it was a life-changing experience. I was able to see people from all different ages that had all different types of procedures. go through all kinds of different struggles. I remember like I had a very big fear about going through the aortic procedure myself, but I met a child that was half my age, that they were on their 4th aortic procedure. And it just really changes your perspective when you see, oh man, like there's so many different ways that people are adapting to this and figuring out their lives. And to be in a space that's very hard to find another space where you're going to even meet, just because the condition is so rare, a handful of other people that have the condition. But when you're at that conference, I mean, yeah, you're surrounded by hundreds of people that have from all different parts of the world that have lived and done this exact same ride that you're going through. And so what I would tell parents, you have to go to at least one. You will learn an incredible amount of things when you go there, even if you're a physician. Like myself, as a 3rd-year medical student, 4th-year medical student, there's just, because the amount of research there's so much new information that comes out. Even the medical professionals that go, we all learn so much when we go. So what I would say is to all those families out there that are hesitant, I'd say give it a shot. Bring some questions with you. Everyone there, like after their sessions, there's a bunch of different panels where people will present on various different topics. You can walk up to them and have a chat with a lot of the providers that are there and ask all your questions, get all of your answers. And it really, I'll say, like you only don't know what you don't know. But once you get there, then that's when it truly is a life-changing experience.
Thank you for that. I think a lot of people come for the medical information and they don't realize how valuable the community is. I had one mom say, I had to drag my kids to the conference, but then I had to drag them out. They didn't want to leave. They met so many friends. So that stayed with me. So thank you so much for your time this morning. I really appreciate your perspective, and I'm sure I'll see you soon. I just have a couple more things I want to share with everybody here today as we close up this session. So if your questions were not answered today, please send them to marfan.org/ask if you have more questions. We will try to get to the questions in the Q&A box. If your name is in there, we can get back to you. That's Stephanie, the new director of our Help and Resource Center. She is a wealth of knowledge. She also has Marfan syndrome in her family. Her husband and her kids have Marfan too. So she is really a great resource for everybody. Also watch for an email from me, because I'll be asking you for an evaluation, and it's really important that we hear what you all think so we can plan future events for you. And I know we have people here from all over the world, so I want to remind you that marfan.org is available in 25 languages, including languages from India, Germany, 25 languages. So you should be able to find something on there that will meet your needs. I know it's easier to get medical information in your own language, so hopefully that helps you wherever you are in the world. Our next webinar for Marfan is on February 25th, later this month, what you and your healthcare professionals should do to effectively manage Marfan syndrome. We know that many doctors are not experienced with Marfan, so feel free to invite them to watch this webinar too. The presenter is Dr. Mary Roman, who's an adult cardiologist. She's at Weill Cornell Medicine in New York City, and she's been on a professional advisory board for a very long time. Wealth of information, also an expert on pregnancy and Marfan. Tune in for that one too. And finally, I want to remind everybody, but February is Marfan Awareness Month. There's a lot of information on our website. Obviously, we do awareness all year long, but we really amp it up this month. You can grab graphics from our website, or you can follow us on Facebook, Instagram, X, TikTok, and just like and share our posts. We also have graphics in several languages, so hopefully there's something there for you. So thank you again for being here today for our presentation, for being here live. We hope to see you again on future webinars, also in-person events. Not only do we have our conference, we have walks in many cities, we have virtual support groups. So we hope to see you online or in person sometime soon. There is my name and email. And if you have any questions or comments, I am always open to hearing them. So thank you again, everybody, for being here today. And we hope to see you again soon.